figure out for yourself what is going on, where is the blood going. So with mitral valve stenosis, we have a narrowed mitral valve, and it's going to inhibit blood flow into the left ventricle because that's the normal flow that it's supposed to go into. So it's going to be more narrow. So that means blood is going to back up into the where? The left atrium. Very good. So it's going to cause the atria to be enlarged. So because of that, that hydrostatic pressure, that backup, that's going to go into the pulmonary veins. So you're going to have pulmonary type of clinical manifestations, okay? So that is how that happens. It's mitral valve stenosis. So it's not going to the left ventricle that well. It's backing up into the atrium. It's making it bigger. And that's going to happen. I hear like, yes. Okay. So that's what happens. That's why you have those clinical manifestations. So you're going to have dyspnea on exertion. When I cough, I'm going to be like, I'm coughing, I have fluid buildup, I'm going to have pulmonary edema. Paroxysmal nocturnal dyspnea. When I'm asleep, when I'm laying flat, I can't breathe because I got all this fluid backing up. So that's paroxysmal nocturnal dyspnea. You will see it again in just a little bit. Don't worry about writing it down. One of the common or most indicative things of a mitral valve stenosis is this opening snap. You can actually hear a snap because that valve is stenosed and it's trying to open like a creaky little, like it's trying to get the blood to go through. So you hear an opening snap. We will talk about atrial fibrillation next semester, but because the blood has backed up into that left atrium, this puts the patient at risk for AFib, so that puts them at risk for a stroke. Don't worry about the diagnosis and all that. You can look at it if you want to. Just worry about the clinical manifestations for now. All right, so mitral insufficiency. So the same thing. This is more common after an MI. Also, people who have Marfan syndrome, they can see that. But the mitral valve is not closing properly, so guess what? If it doesn't close properly, that means blood is still going up into the left atrium as the ventricle contracts. Similar issue, but for a different reason, okay? So this patient is going to have left atrial overload, but they're still going to have pulmonary edema because of what's going on with that valve. So again, this person could be asymptomatic for a while because the blood is backing up. But as the disease progresses, they're going to have issues with things like chest pain because now they're not going to have any blood that's pumped through the rest of the body that's going through the coronary arteries. So this person is going to have more fatigue, weakness, because I'm not getting blood out to the rest of the body. If it progresses, they can have heart failure and edema, and they could be at risk for atrial fib too because the blood is backing up into the atrium. Mitral valve prolapse. Does anybody know what it means for them to be prolapsed? Yeah, yes. So, we're all going to be nurses in here. So sometimes women have prolapsed uterus, right? It's not in the spot that it's supposed to be. So this is kind of the same thing. The mitral valve, for some reason, is just not where it's supposed to be. It's very rare, and this happens most commonly in women. So it's sometimes related to a genetic connective issue. But that mitral valve is loose and floppy, and because of that, the leaflets are thickened, and we're going to have similar issues as we did before. That means that the left ventricle, when it contracts, that mitral valve, because it's kind of like this, blood is still going to go into the left atrium. So you're going to have similar signs and symptoms as well. So anything that has to do with the mitral valve, we're going to remember we're still going to have probably pulmonary symptoms because where the blood is backing up, okay? Does that make sense? Okay. So the aortic valve, on the other hand, if we're looking at our sheet, this is more common, aortic valve stenosis. Again, we have a narrowing, but regardless of the type, we have a narrow and left ventricular outflow of blood. So the left ventricle is going to hypertrophy to compensate for the stenosis. With aortic stenosis, your patient, again, they're going to have very similar signs and symptoms, y'all. So I'm not going to spend too much time on that because really the goal is where is it happening and what is going on behind it or in front of it. With aortic insufficiency or aortic stenosis, aortic insufficiency or regurgitation, you usually see this with rheumatic fever. So that is the etiology of it. Again, with aortic insufficiency, the left ventricle is not pumping blood into the aorta, so there's a backflow in that as well. And because it's regurgitation, we're going to have signs and symptoms of dyspnea, or same thing with like fluid that's going to be deep, that's going to build up in the system. So same kind of signs and symptoms. The diagnosis is always going to be using an echocardiogram on that. So that's why we don't really go over that. Y'all will get that in med-surg. So we're going to finish up and we're going to talk about heart failure real quick. So if you don't know the Frank-Starling mechanism, you don't need to know it verbatim, but you do need to know that it affects contraction or stretch of the myocardium, which is a muscle of the heart. So that is a big thing with heart failure. We're going to look at contractility, and then we're going to revisit preload and afterload, because that's the basic patho of heart failure. So when we're talking about heart failure, there's some words you have to know. So left ventricular ejection fraction, or ejection fraction, that is how much blood by percentage is pumped out of the left ventricle with each contraction. Remember, all your blood does not leave your body. You still have to have some reserve. So if your EF or ejection fraction is 65 to 70%, that is normal. That's a normal ejection fraction. I'll show you some things about systolic and diastolic in a little bit. I don't want you to focus too much on that. This is basically what you need to know about systolic and diastolic function. Again, cardiac output is how much blood is pumped out of the heart per minute. And then remember, your formula, heart rate times stroke volume, is what your cardiac output is equal to. So when we're talking about heart failure, we're looking at preload, afterload, and cardiac contractility. That makes up the basic pathophysiology for patients who have heart failure. Usually when somebody's heart has to work a lot, they usually have a cardiac reserve. So the heart can function and do things like normal, and my body can compensate for it. But in heart failure, this has progressed over time. So the ventricle becomes weaker, and because the ventricle becomes weaker, now my heart is not going to be able to pump blood out to the rest of the body that well, and my heart is also going to cause me to have issues with my breathing depending on what side of the heart is affected. So heart failure is usually divided into some different sections. You can have acute heart failure or chronic. Acute just means it happened real fast. So maybe your pregnant patient developed pulmonary edema and that led to heart failure. Most of the time, heart failure is chronic. It is a progressive disorder or disease. It happens over a long period of time. It is by far probably one of the biggest issues that you see in the hospital, and it affects almost all your organs. All right, so for this class, for this semester, you need to know, are you having right-sided heart failure or left-sided heart failure? And when it comes to systolic or diastolic function, you just need to know what kind of sound am I going to hear, what kind of gallop, what is the very basic issue with it. So is my wall weak or is my muscle weak? And then is my ejection fraction normal or is my ejection fraction low? That's it. Don't worry about all this other stuff right now. Like, don't worry about that. Just worry about those other things right there. Because we're going to focus mostly on right-sided or left-sided heart failure. All right. So like we said before, when we're talking about heart failure, we're looking at three things. We're going to look at preload and afterload, and we're going to look at cardiac contractility. So the heart is going to have to adjust for the cardiac output. And the heart is going to adjust for cardiac output by changing the preload, the afterload, or the contractility. So with heart failure, the issue is that the body has compensated as much as it can, and the compensation mechanism is no longer working. So when we start looking at things that affect preload and afterload, I know we already went over it before, but I want you to remember with heart failure, those are the three things I'm dealing with: preload, afterload, and cardiac contractility. So based on that, the heart is going to try to compensate. And this should say Frank-Starling's law. This should not say pulmonary edema. but that's all right. All right, so these are the ways that the heart tries to compensate for its failure. It tries to make the RAS system work a little harder. So I need to increase the work of the heart by more vasoconstriction. Maybe it's going to stimulate the adrenergic nervous system. It may try to do some remodeling. So the weak heart is going to try to have some cellular changes because it's hypertrophied over time. So it's going to try to use more calcium. Calcium and potassium are your two biggest electrolytes for your heart. Calcium affects cardiac contractility. So that's why calcium is so important with the heart. But these are the ways that the heart is going to try to compensate for what's going on with left ventricular heart failure. So when we're talking about left ventricular heart failure, we're talking about a forward effect or a backward effect. Forward-wise, because that left ventricle is weak, it can't adequately pump blood to the rest of the body. So because of that, you guys have seen this before already, right? You guys remember this? Okay. So because that heart is weak, it's going to try to compensate doing one of these three things. It's either going to say baroreceptors, do your thing, RAS, make it happen, or ADH, you got to help me produce more vasopressin because my heart needs to pump harder or faster because the body is demanding a lot. So that's how the heart responds to left-sided heart failure. Because we're talking about left-sided heart failure, that left ventricle is going to back up and it's going to cause hydrostatic pressure. So it's going to back up into your pulmonary veins, and this is where you have things like shortness of breath, edema, dyspnea on exertion. Left-sided heart failure is going to produce more pulmonary issues than right-sided heart failure will. Okay? All right, I'm not going to go over this. This is basically just saying what I said, but this is left-sided heart failure, and these are our clinical manifestations. So your patient with left-sided heart failure is going to look more like a pulmonary patient because that blood is backing up from the left ventricle back. So they're going to have orthopnea. What is orthopnea? I heard it. So trouble breathing when I'm laying flat, right? So fluid builds up and I have trouble breathing while I'm laying flat. So when your patient is supine, they can't breathe. So they need to sit up so that way the fluid kind of moves and they feel like they're not drowning in their lungs. Because you have more pulmonary congestion, when you listen to your patient, they're going to sound wet. They're going to have crackles. They may even have wheezing because they're trying to catch their breath from all the fluid. They're going to be tachypnic. So their respiratory rate is going to be what? What's high? Greater than 20. Very good. Greater than 20. It could be greater. It could be 100. I got what you meant though. Definitely. All right, so exertional dyspnea, when I'm trying to get up and move, I'm tired because everything is backing up, okay? This just explains what we just talked about, so that way you have the patho behind it, but this is that paroxysmal nocturnal dyspnea, and then that's orthopnea, shortness of breath while laying flat. And then again, this is orthopnea. So your patients typically will be more comfortable at like 30 or 45 degrees. And these are usually the patients who need like 3 or 4 pillows to help them sleep at night. Right-sided heart failure, the backward effects are more significant because now I'm talking about issues related to the peripheral circulation. So I have this increased venous pressure. So all of my organs are going to start having fluid buildup. With right ventricular heart failure, you're going to see more of that like dependent edema. You're going to see a bigger belly. And then for your patients who have pulmonary things like COPD, these are the patients that can have pulmonary hypertension. These are your right-sided heart failure patients. So the backward effect is going to be more significant with JVD, which is jugular vein distension. So when this patient is laying down, you can see those veins in the neck really bulging out because of the increased pressure that right ventricle failure has conducted. These patients may also have ascites, they may have enlarged liver. They also could have some hypoxia, but they mostly are going to have swelling in the legs, and they're mostly going to have things like JVD. JVD, again, like we said, is jugular vein distension. So this happens with the congestion in the superior vena cava. So you're going to see this more when your patient is laying down or laying less than 45 degrees. You'll see that JVD more. And then this is going to explain a little bit more of what's happening or what happened to give you that swelling of the ankle, the hepatomegaly, and the ascites. It has to do with that blood backing up into the system and causing fluid buildup. So with right-sided heart failure, again, this patient is going to have more issues of dependent edema. They're going to have swelling in the stomach and in the liver. And you may not be able to see the swelling in the liver as much, but when you feel their stomach, it's going to feel hard. And that's going to be fluid that's accumulated in their body. With these patients also, with their edema, it's going to be pitting. So it's not just that their legs are big, but when you touch it, it's going to have that indentation. So these people are going to have pitting edema. And then cor pulmonale, so this is a result of right-sided heart failure. Somebody who has COPD, even though they have COPD, they could also have right-sided heart failure, and that's called cor pulmonale because of where the pulmonary arteries and valves are concerned as it relates to the right ventricle. So remember we said the pulmonary system has its own circulation, so that means that it can have hypertension as well. So cor pulmonale is hypertension in the lungs. That's what that is. All right, and then this is just another visual for you to kind of put those two and two together. So that's that. Are y'all still with me?